all the way from Geneva, we are going to have Ms. Floriza Gennari, who is a behavioral scientist and public health specialist who is focused on integrating gender and GBV into programs, particularly those related to sexual and reproductive health and HIV/AIDS. She recently authored the World Bank's Violence Against Women and Girls Resource Guide and also co-wrote PAHO's Regional Strategy for GBV. And Floriza led the AIDS-free review of the GBVI in Mozambique, so we will hear from her about that now.
Good morning. My name is Floriza Gennari, and thank you so much for all being here. In this presentation, I'm going to go over some of the highlights from the GBVI in Mozambique. There were numerous and very exciting activities and efforts that were undertaken, but for the sake of time, I'm going to cover only a few of these. So in addition to reviewing over 390 background documents, reports, and presentations, myself and a local consultant, Terrace Handy Harris-Sapp, we undertook approximately 46 interviews with individuals and groups from 19 organizations. Additionally, we visited La Fela, a one-stop health facility for post-GBV care, and Buzi, where GBVI partners are working on GBV prevention efforts at the community level in particular. And finally, after 2 weeks of very intense data collection, we conducted a culminating session with key stakeholders to present and validate some of the emerging themes. Next slide, please. As has been mentioned, GBV and HIV are dual epidemics in Mozambique. In Mozambique, HIV prevalence is estimated at approximately 11.5%, with women disproportionately affected, and more than a third of women aged 15 to 49 report having experienced any form of gender-based violence in their lives. The country also has one of the highest rates of early marriage in the world. There are also reports of sexual violence affecting boys, orphans, and other vulnerable children. Next slide, please. Just an overview of the project in Mozambique. It was a 3-year project, over $21 million, numerous implementing partners involved. And unlike other GBVI countries, the initiative in Mozambique was implemented nationally across all 11 provinces. The initiative also employed a multisectoral approach, including the Ministry of Health, Ministry of Gender, Children and Social Affairs, Ministry of Interior, responsible for the police, and Ministry of Justice. Ministry of Education was involved to a lesser degree, and as well as that, the armed forces of Mozambique were involved heavily. The objectives of the GBVI included expanding GBV prevention efforts, improving the policy response to GBV, as well as improving the quality and availability of GBV services. Next slide, please. This is just to give you a flavor for the number of partners involved in the GBVI in Mozambique. This gives you an idea of the extent of the services and the initiatives and the activities that were undertaken in Mozambique over the 3 years. Next slide, please. So as I mentioned earlier, the GBVI Mozambique was implemented at national level, and in red you can see where the GBVI had clinical partners working on post-GBV care, primarily within health facilities, but not limited to them. And in blue, you can see where both community and clinical partners were working. That is, there were both GBV prevention and response efforts taking place within the same province. Next slide, please. I think that one of the highlights of the GBVI in Mozambique was the multisectoral approach used, which built upon existing country-level commitments and initiatives. So, for example, the country already had several victim service centers at police stations, and as early as 2008 had a multisectoral plan to address gender-based violence. And although there were several aspects of these efforts that needed to be strengthened, the GBVI was nonetheless able to work with key stakeholders to improve the country's response to GBV by adding in the health sector to a multisectoral strategy, for example, and by creating synergies at different levels. So at the provincial and district level, the GBVI excelled at setting up working groups comprised of representatives from the Ministry of Health, Ministry of Gender, Children and Social Affairs, Ministry of Interior, and Ministry of Justice. Now, what was really special was that these groups, made up of individuals such as police officers, nurses, administrators, etc., were all trained together on GBV prevention and response. And they also met on a regular basis to discuss bottlenecks and challenges within the referral pathway for survivors. The GBVI also contributed to the establishment of one-stop models in 5 provinces, where survivors were able to access a host of post-GBV care services within one location, which greatly helps with reducing the chance of re-victimization. Where it was not possible to set up one-stop models, as this tends to be resource-intensive, GBVI partners work to creatively engage with different sector actors to attempt as much as possible to provide different post-GBV care services within close proximity. So, for example, oftentimes the healthcare provider would be trained in forensic pathology, or a police officer would be placed within the health facility to avoid having the survivor cross town to access the police station after seeing the doctor. And similarly, police officers knew to refer the survivors to the health facility immediately when they came to the police. Next slide, please. The GBVI also made great strides in establishing community clinic linkages. At the community level, prevention partners use participatory and gender transformative approaches to change social and gender norms around the acceptability of gender-based violence and to increase demand for post-GBV care, while at the health facility level, clinical partners work to improve the quality and availability of post-GBV care. So in essence, they're working on supply-demand at the same time. Additionally, almost every single respondent interviewed mentioned that they were working with a local NGO or community organization, which was crucial for ensuring linkages between communities and clinics. And this was also so important for obtaining buy-in from village chiefs and key opinion leaders to address GBV within their communities and urge survivors to seek post-GBV care, but also to encourage the widespread behavior change by having them lead by example. We heard so many stories of community leaders taking really strong stances against gender-based violence and urging other men and women to do the same. One of the most successful examples of community clinic collaboration was the one-stop site, Tlapela Hospital, Maputo Province, which was a demonstration site, but it was really incredible in terms of how the clinical partners provided technical support within the health facility, while community partners worked through peer educators, for example, who did HIV counseling and testing in the surrounding community and integrated into their work GBV awareness raising activities as well as behavior change efforts through discussions with the communities, debates, etc., to encourage individuals to come out and not only seek testing, but also for survivors to seek post-GBV care. And then the other thing was that within Tlapela facility, the GBVI provided a community point person who had a very sophisticated mechanism for basically helping referrals from the community obtain post-GBV care services by escorting them through the different services available at Tlapela. And as much as possible, like I said, this is resource intensive, but different one-stop models throughout the country attempted to emulate Tlapela's example. Next slide, please. So not only does Mozambique now have a national protocol and clinical guidelines for post-GBV care, as shown there, the 2 pictures, as well as post-GBV services throughout the country, many GBVI activities have been institutionalized within government structures and are now part of the government's plans, strategies, and budgets. GBV prevention and response is included in Mozambique's 5-year strategy and within the health sector plan, which is no small feat, especially as it also includes an assigned budget. Additionally, gender-based violence modules are now part of the pre-service curricula of nurses, physician's assistants, and police officers. Both training and funding for forensic pathology are included in health sector plans, which is an essential component for promoting access to justice. So not only will post-GBV care services established throughout the country remain in place, but the multisectoral mechanisms and working groups that have been institutionalized will also remain. We really witnessed so much enthusiasm and interest in working on this multisectorally and really intense engagement from the different partners involved. So finally, I will leave you with a quote from one of our respondents. I will recall that previously there was nothing before the GBVI. We now have programs where GBV is integrated, we have messages that are delivered, and we have information. The impact is there, but there is still a lot to be done. Next slide. Thank you very much for your time and attention and for bearing with me as I call in.